Welcome, everyone, to the Leonard Davis Institute's virtual seminar series. I am Rachel Werner. I'm LDI's Executive Director. Today, we will be having our final seminar series in a series of COVID-related virtual seminars that we've hosted over the past few months. We'll be talking about health insurance coverage in the aftermath of COVID-19 to top off the seminar series for June. We're going to be taking a break from over the summer from these seminars, but please remember to join us in the fall when we'll start back up with a lineup of exciting additional seminars. Today's seminar is going to be moderated by Dave Grandy, who is LDI's Director of Policy, and I will turn it over to him now.
Thank you, Rachel, and I would just like to echo saying good afternoon and welcome to this seminar. We do plan today to discuss the future of health insurance coverage in America, and as the audience knows, there's been massive disruptions occurring as a result of COVID-19. If we go back as far as the 1950s, employer-based health insurance has been the bedrock of private insurance in the United States, and certainly Medicare and Medicaid stepped in during the 1960s to fill large gaps in the system. And then, of course, the Affordable Care Act in the past decade has attempted to fill in even more gaps in the system. But now the country is facing unprecedented job loss, and with that, millions of Americans are losing health insurance. The Robert Wood Johnson Foundation and the Urban Institute recently estimated somewhere between 25 and 43 million people are likely to lose their health insurance as a result of will lose their employer-sponsored insurance as a result of job loss. There are enormous questions about whether the nation has an adequate safety net to ensure that people can obtain alternative coverage, whether they can access the care they need, and do so without facing catastrophic financial hardship. And that is really the essence of what we will talk about today. So we have four great panelists, and let me go ahead and introduce all four before we jump into our conversation today. First, we have Larry Levitt. He's the Executive Vice President for Health Policy at the Kaiser Family Foundation, and he leads their work related to public insurance and the Affordable Care Act. He was previously Editor-in-Chief at KaiserNetwork.org and worked in the White House during the Clinton administration. Next up is Mark Pauly. Mark is the Bentheim Professor in the Department of Healthcare Management here at Penn in the Wharton School. He is one of the nation's leading health economists and international experts on health insurance economics. Next up, we have Jamila Taylor. Jamila is the Director of Healthcare Reform at the Century Foundation, and she leads their work on planning next steps for health reform to build on the Affordable Care Act. She is an expert on women's health, reproductive rights and justice, and racial and gender disparities in health. And she was previously at the Center for American Progress, and before that, a global NGO focused on women's health. And lastly, we have Hemi Tuarson as the Director of the National Governors Association's Center for Best Practices Health Division, and there she works on Medicaid, healthcare delivery and payment reform, opioids, behavioral health, and social determinants of health. And she previously worked as a senior attorney in the Office of the General Counsel at GAO. Let's go ahead and jump into our discussion today. And I want to start with a rather broad question before we get into a lot of the specifics about what's going on with health insurance today and some potential policy approaches. But the big picture question, which is, how is COVID overall impacting health insurance in America, and who is being impacted most, and what might that mean for health and healthcare, in the immediate future? And so I want to kick that first question to Larry to get us started.
Thanks, David, and thanks for having me. I think the important thing to remember is that we have a double whammy right now of a public health crisis and an economic crisis, and that those are both having tremendous effects on health insurance coverage. The first, as you mentioned, is that we are seeing historic job losses, and that could lead to substantial historic increases in the number of people uninsured. Anecdotally, many employers are preserving health benefits for laid off or furloughed workers. So I don't think we have yet seen a big increase in the number of people uninsured. But if the unemployment rate remains high, that could certainly be coming. And you mentioned estimates. I mean, we could see tens of millions of people losing job-based insurance. At the same time, the public health crisis and the social distancing measures that have been put in place to deal with it have really upended the healthcare system in a way that we have never seen before. In the middle of a pandemic, providers are losing money because of declines in non-urgent procedures. I mean, tremendous declines in non-urgent procedures. We saw a huge drop in healthcare use and revenues in late March, April, and May. And that has had the somewhat unexpected effect of insurers, being flush with money right now. Insurers are not paying claims, so insurers are, looking for ways to spend money, talking about premium rebates to avoid some of the rebates they'll be required to provide to consumers and businesses under the Affordable Care Act's medical loss ratio provision. So, this combination of a public health crisis and an economic crisis has really upended the health insurance.
Great, thanks, Larry. And I think we'll come back to that question of how insurers are managing their both short-term and long-term finances a little later in the conversation. Hemi, I want to make sure we look at the states in this conversation as well. But many states, obviously, like a very short-term effect of what we're going through right now is a collapse of state budgets. But if we see a lot of these impacts on employer-sponsored insurance play out as we expect it might, we'll also see, of course, a lot of demands on safety net insurance programs, Medicaid in particular, run by the states. So what's going on in the states? What are the conversations right now? How are states looking at this looming budgetary crisis?
Well, thank you for having me, and it's such an important question. I'm so pleased to be here as part of this discussion. So, for those of you who aren't familiar with NJA, we represent all governors across, Republican and Democratic parties, and they have been meeting weekly through our association, which is somewhat unprecedented. They don't usually do that because of the nature of what's been happening with COVID-19 and just the significance of it. And, every conversation is about budget in some way, shape, or form. And then also, of course, how are they responding to the public health crisis? And I will say, in the shorter term and longer term, that is going to be the issue. So, states right now, they have to balance their budget. They're not the federal government. They have to balance it within a 1 or 2 year window, depending on the structure of their state. And that means there is no borrowing. I mean, they have to make really hard decisions about knowing that they're going to have really big shortfalls in their state revenue for, things like tourism and some of the, economic drivers that they have in their states that are not going to be at the levels that they were just a few short months ago. We were talking about states who had millions and millions of surpluses or, going to have millions and millions in deficits just in this next year. And so one of the things that we've been talking to the governors about, and they've really been thinking about, is how do we plan for that? And with respect to coverage, I do think they expect their Medicaid rolls will increase significantly. I think they expect their exchange population will also increase significantly through the state subsidies because people will lose jobs. Now, how that economy comes back in the fall, there are different predictions and, there are different things that are being, assumed. Maybe we won't have a wave 2, maybe we will, there will be a difference in that. But if you look right now at the unemployment numbers, even within the state employees, they're very high. And some of the areas where they have made some cuts, now maybe it's short term because of what's happening with schools, are with the teachers. So there has been a fair number of teachers that have been laid off. They may well get hired back in the fall. I think that's all to be determined. But I think one of the things that we're most concerned about is without additional stimulus money, and that's why NJA has a request to Congress for $500 billion. And that's across all governors, conservative and progressive alike. They really feel the need for that stimulus money to help jumpstart their economies, which they think they know are going to be in pretty significant straits looking forward. I also think, in the shorter term, there's what's happening within, 2021. But I think for some states, and, there's economists on these lines, so I'm not an economist, but there is some predictions that it will take, 3 to 5 years for some of these states to get back to where they were. So it's a really significant concern.
Great, thanks for that. And maybe just as a quick follow-up, does it seem like there's any growing political momentum around federal support for state budgets at this point, or is that still kind of stuck at the moment?
I mean, we are certainly still lobbying pretty hard from an NJ perspective for that $500 billion stimulus. We also are requesting an enhanced federal medical assistance percentage, FMAP, for Medicaid up to 12%, because that is also an important economic driver for states. So that is also part of our package, and we also are continuing to advocate for unemployment insurance. I think there is some conversation continuing to go on. I think it's at a slower pace. I don't think we'll see something happen quickly, but our perspective is that communication lines are still open, and I think there's an appreciation. We had 3 governors testify last week in Congress about what's happening with COVID, and they certainly talked about this aspect of it, and more conversations are going on that front. So, we're hopeful something will happen.
Mark, let me ask you, as I mentioned in the opening, obviously employer-based health insurance has been really the cornerstone of health insurance market for decades in this country. Do you think there are many ways everyone's talking about how COVID may permanently transform some aspects of American society. Is this a part that will be permanently transformed if there really is disruption in employer-sponsored insurance? Like, do we think that the mix of public and private coverage may end up changing as a result?
Well, so I'll give the standard economist answer. It all depends. But it depends on 2 things. One is, well, what is going to happen with the employment situation? It's 13% unemployment, the last number. There's some hidden unemployment because some people, as Larry mentioned, are being paid even though they're not working, but they're still getting their health insurance. So it's not yet a problem for their health insurance. And at least the most pessimistic forecast I've seen, I'm not going to take the blame for any macro forecast, was from Jerome Powell that killed the stock market this week, saying by the end of the year we might be at around 10% unemployment. So we're not talking about Great Depression numbers, I don't think, although it's always worrisome. My dad worried about it his whole life. We're talking about Great Recession numbers, which are more like a 10%, 9% unemployment rate. And the one message we have from past history is that event did not provoke a dramatic change in job-based insurance. And one way to think about that is if 10%, and that's kind of what we would be talking about, 10% more people would lose their job-based insurance if they were the only worker and their spouse was not working and all those things. Well, 90% of people would retain their job-based insurance. And I don't know what your view was of the Democratic primary, but my view was that I don't have a particular preference to this point of view, but it looked like the people who like their job-based insurance won over the people who wanted to substitute some other kind of insurance. And I guess that's the big political unknown. What's the alternative to job-based insurance? Right now, if I lost my job, and had to go to a silver plan on an exchange, that's pretty terrible insurance compared to what I have now. I wouldn't really want that. I'd read better than nothing, but it's not nearly as good as what I would have now. So I wouldn't want to trade off that way. And of course, it depends on what happens in the election in November. And as long as, so who knows? It's as hard to predict politics as it is to predict the economy, if not harder. But if the Republicans retain control of the Senate, I don't see any dramatic change as an alternative. And if the alternative is ultimately what Vice President Biden is proposing, which is basically Obamacare, that certainly helped out in the Great Recession, although that didn't really kick in until 2014, a little too late, but at least it was something. I guess I don't see the rationale for a dramatic change. Remember, employment-based insurance isn't a government program, although now it's supported by the tax exclusion. It was chosen by workers and by unions and their employers voluntarily as a way to get health insurance at a low price. And of course, it was, as I said, the pot was sweetened by the fact that you could get a tax break. So my punchline is, objectively, I don't see, unless the recession becomes a catastrophe, in which case everything's at risk, including, the government's going to have to provide you with housing, the government will have to provide you with food, everything will be at risk. If we don't go there, and golly, I sure hope we don't, if we have a recession, mild is not the right word because you never want to have a recession, but a sort of a Great Recession style downturn, objectively, I don't see a strong rationale for changes. And politically, of course, your guess is as good as mine, but I wouldn't guess that there'd be a revolution there either.
Thanks, Mark. Jamila, I want to ask you, you've done a lot of work looking at structural barriers to access to care, racial and gender disparities in health outcomes, the relationship between healthcare and economic justice. We know that COVID-19 has taken a real severe economic and clinical toll on communities of color. And what sort of policy changes at the federal or state level are needed to really help mitigate both the extensive job and insurance losses in the communities along the lines of what we're talking about?
I enter into these conversations, with the fact that, the situation for people of color in this country in terms of both healthcare coverage and the economic challenges were there before COVID-19. So I think it's important to sort of put that fact out there to ground the conversation. COVID-19 has made things much worse for these populations. So we're seeing an overwhelming majority of frontline workers and essential workers are women and people of color. And so as the conversation moves forward with the rush to reopen, I think it's important to say that their safety needs to be first and foremost in any conversations about moving the country forward in that way. So wanted to put that out there. And so when they are able to get back to work fully and able to do so with dignity and to do so safely, we need to first make sure that we have enough testing for everyone. The United States has fallen way behind in terms of ensuring access to testing. Testing needs to be universal and it needs to be free. I think that's first and foremost. We also need to make sure that if folks do fall ill, largely our frontline workers, that they have access to treatment, and that treatment should also be free. All workers need to have access to PPE. Universal paid leave. This is something that we've seen, particularly in the context of COVID-19, that has fallen way short for these populations working on the front lines. So on one hand, they're putting themselves at risk to contract COVID-19, but they don't have access to the worker protections that they need in case they do fall ill or have to care for a family member that falls ill. We also need to ensure, access to wages that help these populations thrive. So not just livable wages, but wages that can help them thrive. Universal health care is another key piece here. So ensuring that all families have access to health care that is affordable, that is not connected to a job, I think is also essential. We've already talked about in the program today how millions have already lost their access to employer-sponsored insurance. Millions more risk losing that access. And so I think as we talk about all of the great gains that we've made through the Affordable Care Act, I think it's time to move the conversation towards how can we ensure access to health care for all people that is affordable and is of the highest quality. And then the last point that I'll make is access to childcare. This has been a key component. The childcare industry has been, pretty much decimated due to the pandemic recession. And so there have been calls to increase funding to support the childcare community to get back up to where they need to be to ensure that families have access to childcare. And this also is going to help the parents out there that do need to return to work to do so with dignity and with the assurance that their children will be taken care of. So those are just a few of the things that we're recommending based on conversations we're having with the Hill. There have been some incremental changes in some of the initial packages to respond to COVID-19 on some of these issues, but quite frankly, I think most of those packages have fallen way short to address these issues.
Seems like in the past couple of days, people have, there was a degree of complacency that was starting to be evident in the country. We'll just reopen everything. This first wave has passed. And then in the past couple of days, I think people are acknowledging the fact that there's a resurgence of COVID. I think in 21 states were reported yesterday where we're seeing, rates go up as opposed to go down. Do you see that as creating any momentum for some of the ideas that you're talking about to bring these policies forward to protect a lot of these workers?
If we sort of look at this moment that we're in this country where, I think lots of folks are speaking up about sort of broader issues in terms of injustice in this country. People are also starting to talk about some of these other intersectional issues. Do I have health insurance that is affordable that I can access? Can I be safe in my neighborhoods? Do I have access to clean water, food in my community? So I do think that we're in a special moment where, we're seeing folks that are quite frankly fed up with not having the access to the services and support that they need. And this is all interconnected. Having healthcare access is interconnected. I would also say that in the media, we've seen stories of, frontline workers, largely people of color, that have been turned away from testing or treatment only to become gravely ill. And some of them have actually died due to COVID-19. So when these things happen, it's causing communities, quite frankly, to be upset and to call for these changes. So not only are you seeing people protesting, about these things, they're also reaching out to their members of Congress and saying, we'd like to see more from you in terms of support to recover from COVID-19. We need another round of stimulus checks to support families that are quite frankly struggling right now. But we also need to make sure that testing is available to everyone, as well as childcare and some of these other issues I mentioned. So I think it's just an important point in our country right now where everyone is feeling emboldened to talk about the issues that are impacting them personally, and healthcare and COVID-19, the economy. These are all things that are interconnected as well.
Larry, I want to ask you, if we look at the Affordable Care Act and the pieces of the ACA that were designed to help fill in some of the very gaps that we're talking about today, what do you think the ability is of the way the ACA was designed to kind of step in during this pandemic and fill in the gaps and the cracks in health insurance that are quickly forming, and what are the parts that are missed by the ACA as we think about some of the gaps in policy that need to be addressed?
I think you can't overstate the power of the ACA as a safety net in a recession like this. As Mark said, the ACA passed and was implemented in the wake of the Great Recession, but was really not there as a safety net. This is the first economic downturn where we have the ACA in place as that safety net. And importantly, we recently put out estimates showing that 79% of people expected to lose their job-based insurance as a result of job loss will be eligible for help under the ACA, either through Medicaid or through ACA marketplace subsidies. So that's enormous and a cushion that was not there before. But there are some gaps. If 79% are eligible for help under the ACA, 21% are not, and that could certainly be millions of people. While Medicaid generally has no or minimal premiums and cost sharing, that's not true of ACA marketplace plans. Mark mentioned silver plans. they can carry, even for low-income people, pretty substantial premiums that may feel unaffordable, as well as deductibles, even after cost-sharing reductions. And I think there's a real lack of awareness and understanding. I mean, many people who are losing their jobs now have never had to rely on Medicaid or the ACA marketplace, and may not even know or understand their options. And the Trump administration has reduced outreach by 90%. They've reduced grants to community-based navigator enrollment assisters by 84%. So the application process, which can be complex, could be really hard to navigate for people. If and I think Hemi talked about this, while ACA marketplace subsidies are funded federally, and the federal government covers the vast majority of the cost of Medicaid expansion enrollees, 90%. That's not true of parents or children who were eligible for Medicaid before the ACA. So there will be substantial state costs as there is greater enrollment in Medicaid. And I would say, I mean, I agree with Mark that I don't think we're in for a revolution in employer-based insurance in this period, either economically or politically. But what I think we could see is a solidification of the ACA as part of our health insurance system as more people rely on it.
There's actually a question in the Q&A box from one of the audience members about whether or not the pandemic will change the discussion or politics around Medicaid expansion in the states that haven't expanded, and any chance that Congress will boost federal funding for expansion to 100% for remaining states. So, Hemi, I don't know if maybe that's a question for you. Are we seeing any revisiting of expanding Medicaid in the states that have not done so yet, or at least conversations about doing so?
Unfortunately, no. And they're actually, we've seen some action where they're going in a different direction. So Oklahoma, for example, had a proposal in to expand its Medicaid program, which they are now withdrawing. Kansas was another state that had been, their governor, Governor Kelly, had been really interested, and I think she's still interested in expanding Medicaid. But unfortunately, with the budget pressures they're facing and the anticipation of the increase in the rolls, we are not hearing, and this is us just at NGA, we are not hearing from our state leaders about real interest or momentum towards Medicaid expansion.
Do you think that would change if Congress came to the table with, something that looks like 100% funding again of Medicaid, which is how the Medicaid expansion at least was initially funded?
I don't know if that will change enough. I mean, even with the 6%, so Congress provided a 6% increase in the FMAP, and they required a maintenance of effort. So in order for states to qualify for that, and so right now, states are not able to do, if they have big budget cuts, the only thing they're really able to do is cut provider rates. And that's going to continue on. And we, of course, are advocating for the 12% increase because we think more is needed. But I think there's a real concern that they're not going to be able to cover their current budget. So I even think with 100%, going from 90 to 100, that's not going to be enough to address the kind of bigger shortfalls that they're worried about. Because just to remember, states have to balance their budget, and the two biggest drivers of state spending are Medicaid and education, generally speaking. So those are the two areas they go to first to figure out how to kind of balance when they don't have the state revenue they need to fund the budget fully.
Mark, I want to come back to a topic that came up, I think, in Larry's initial comments about what's going on with the finances of health insurance companies today. So, spending for healthcare has fallen off a cliff as the healthcare system has almost overnight been turned off. And in fact, even as it's reopened, I think there's a lot of concerns about whether patients feel comfortable re-engaging with the healthcare system. I know I opened my mail this week and I had a rebate check from my car insurance company because everybody stopped driving over the last 3 months. Now, it wasn't as much as I thought maybe it should be, but nonetheless, there was a rebate. What's going on with the kind of bottom lines for health insurance companies? We have, kind of two dimensions of customers, I guess we think about. We have the covered individuals themselves who are obviously using a lot less healthcare and had contributed premiums. whether directly or indirectly. And then we have the providers who are used to getting paid from those premiums and really struggling financially, and in some cases at the risk of closure. So what do we know about the current state of the bottom line of health insurance companies, and how they're thinking both in the current premium year but also next year?
First of all, what seems to be the case, despite what some experts in California claimed, is that health insurance premiums are not going to take a big jump, mostly because, as you mentioned, claims actually went down rather than up. Usually, when we teach this, we tell students insurance is a great thing for covering independent events. I get a heart attack, you don't. You pay to help me out, effectively. That's how insurance works. In a pandemic, if it was literally a pandemic, that wouldn't be possible because we'd all be sick. But what happened was that people either held off mostly, I guess. I'm not sure they were necessarily paying, although to some extent, of course, by staying home, you didn't jump in your car, you didn't have an automobile accident either, but there was a pooling across different kinds of diseases where high costs for treating COVID-related disease were offset by low costs for other diseases. So in some ways, it's not as bad as it could have been. Look for a bright lining in the cloud. Of course, what's crucial is what will happen going forward. But my guess is that the biggest challenge for insurers is, as always, they don't know what's going to happen any better than the rest of us. And usually, I don't want to be insulting, but it seems to me it's a great life to be an actuary because most of the time you can just thing on autopilot. But that's not what's going on now. And so insurers are going to have to make some tough calls if they're thinking of what premiums they're going to charge next year without anybody knowing what's going to happen next year. There is one thing, though, that I think it's important for people to keep in mind. As you mentioned, most Americans get their insurance as private insurance through their job. And among those, most of them have what's called self-insured plans. So that's my plan at Penn. It's managed by Blue Cross, but Blue Cross is not the company that's out of money or that's coining money if claims have fallen. It's the University of Pennsylvania's financial system. I'm not sure where the money exactly piles up, but when the adjustments are made at the end of the year for how much did Blue Cross administer to lay out on behalf of Penn employees in my plan, that'll be good news for Penn. And so the question is, the question to which I have no answer is, well, then what are employers going to do? Their premium, for one thing, the self-insured premiums are going to jump around. For another thing, there is no good mechanism or even any mechanism for adjusting response to changes in self-insured costs, whether it's plus or minus, other than by changing next year what you might have to pay as your explicit payment, which of course is only about a quarter of the total cost, or I guess giving us all a bonus, right? A wage bonus, because the university they sent me a statement last month about how much they paid toward all of these fringe benefits. If this fringe benefit is cheaper, I'm expecting a check from Amy Gutman too, from President Gutman, as a refund on the employee Penn's contribution toward my health insurance. But the punchline, I guess, here is this is a source of enormous confusion. Then the fallback position is it's hard to predict. But it's certainly much more complicated than you could have possibly imagined. Rube Goldberg has never died when it comes to health insurance.
There's a question, which is an interesting one about, I think a lot of how we're thinking about what will happen to employer-sponsored insurance is maybe not quite happened yet. These are a lot of projections about where we might be heading. And so that's basically the question is, have we seen the losses yet? And if not, why not? What's kind of holding the system together?
I mean, I think that's right. We projected, and you mentioned some other projections from Urban Institute and others as well, that there could be tens of millions of people losing job-based insurance. We estimated 27 million. But I think it's pretty clear that has not happened yet. The job losses were so fast and so big, and employers just really didn't know what this recovery was going to look like and how quickly it was going to come. Whether it was going to be a V-shaped recovery and a really sharp V. And employers wanted to keep, in many cases, keep a relationship with these workers so that they could reopen and recover quickly. So in some cases, the government is helping pay salaries and benefits for workers through the payroll protection program. In many places, even if employers have laid their workers off or furloughed them and they're getting unemployment compensation, the employers are still providing their health benefits. It's all anecdotal. There's no systematic data, but I think it's pretty widespread that employers are continuing benefits. And that was true in May. It was true in June. I think this month, if employers are not calling workers back, we're going to start to see those benefits disappear. And I think as we get further into the summer, if unemployment remains high, we will see big decreases in job-based insurance.
Let me just make one comment on that. One of the safety valves for the employment-based system is the requirement for COBRA continuation, which says if you no longer get insurance as an employee, you can continue for up to 18 months to continue to get insurance, but you have to pay for it. And most people get a sticker shock because they think they may know what they're explicitly paying. For me, it's about $4,000 a month, but they for family coverage, but they don't know the 80% or so the employer is paying. So that's the sticker shock, and for a lot of them, it's quite, not only did you lose your job, but also now you're going to have to pay $15,000 or $20,000 for your family coverage instead of $4,000 for your family coverage. What a hit. A potential solution, of course, is since you should be on unemployment could be arranged like your salary is arranged, in which some portion of what would have been your unemployment payment is taken out and used to pay toward your health insurance, toward your COBRA continuation, so you can continue to retain that and kind of keep it up, and you avoid the sticker shock because you never saw the money in the first place. So there may be some attempts. I think there have been some discussions of how the government might help with COBRA continuation, and there is a balanced budget model of that, I guess is what I'm saying. If you fix the total amount to be paid as compensation to unemployed people by diverting some of that at the beginning toward their health insurance, which of course everybody ought to have. I mean, it's preposterous that we have people running around out there without health insurance.
Just wanted to follow up really briefly on that point, that the HEROES Act does include a provision that would allow subsidies for COBRA for folks that needed to continue with that coverage. So just wanted to put that out there. Of course, we still don't know what's going to happen with the HEROES Act in terms of conversations with the Senate and how they're going to move forward with a package that, both sides of the aisle can agree on. But did want to put that out there and to say that's something that we can be advocating for in the Phase 4 package to address COVID-19.
And Jamila, Hemi maybe painted a not so optimistic view of, Medicaid expansion. I think, a lot of, things you've written about is about the incredible importance that Medicaid plays in addressing gaps in coverage. What do you see as potential ways to try to push states forward to get the federal government to do more? Like, what is it going to take to get the rest of the states to join Medicaid expansion that was envisioned as part of the ACA?
We do have a pretty grim picture in terms of the situation with Medicaid now. States, are having budgetary issues. At the same time, you have more Americans that are having to rely on Medicaid for healthcare because they have lost their employer-sponsored health insurance. And, as Mark pointed out, may not have the money to pay for COBRA for that continuation of coverage if it even is offered to them. I mean, most Americans don't even have $400, to cover an emergency if they have one. So in terms of the Medicaid conversation, Medicaid is in the center of, what we're advocating for in terms of, how we can ensure that people do have coverage in this critical moment. And some of the things that we've been advocating for to incentivize states to expand Medicaid, and I think this may have been mentioned earlier, was increasing the federal matching to 100%. And then also we've been advocating for implementation of an automatic stabilizer that would ensure that the federal share of Medicaid costs would go up when state economies go down. And so really trying to think through how to support states in this important moment, because they are, experiencing some budgetary challenges with more Americans having to rely on the Medicaid program for coverage.
Yeah, this seems to be a story that gets told over and over again that happens during recessions as states go into these emergency budget situations and start cutting, which of course is at the very time that need grows. Hemi, this idea of an automatic stabilizer, is that something that you think would bring some confidence to state policymakers to consider stepping forward in terms of mitigating risk about expansion?
I don't know. I think there's so many concerns around just how they are going to keep their budgets whole and not cut a lot of different programs. I don't know if that's enough, to be honest. And it's not just the governor. I mean, there's also the state legislature. I mean, the states that haven't expanded. In some states, you have a Democratic government that would be in favor of it, and you have a Republican-dominated legislature that is not. And those conversations were hard before COVID-19. And I think, right now there's conversations around, for example, how is federal stimulus money going to be allocated? And some governors are waiting on their legislature to figure that out. And legislatures haven't been, convening. And so, the politics is still there. And there's also sort of an additional layer of the budget realities. So I don't know. I never like to predict anything these days because you never say never. But we certainly haven't been kind of hearing that. I mean, the $500 billion that we're asking for is really to shore up state economies to make sure that they can, get their people back to work and, maintain the systems that they currently have. And that's really kind of the ask that we're making. One observation I just did want to share on the Medicaid enrollment numbers, because I think it was in the chat too. We have been perplexed about, why are we not seeing more people, coming onto the Medicaid rolls right now? We thought there'd be more by now, and it's increasing, but it's slowly increasing. We're actually just talking to some state officials about that, and one is speculation around, okay, are there sort of more people that are able to access COBRA, and the big decline in the employer-based insurance that we experience obviously correlates to people signing up for Medicaid. But there was also a conversation around, because people aren't going in for healthcare services, is there just the slowdown of people, even thinking about insurance? Everyone's kind of been, locked down and, in their own spaces. And so they haven't really been focusing on this. And as we start to reopen, are we going to see sort of more movement in that direction, get to the numbers that people had predicted originally? I just wanted to make that comment, that's something that we've been talking about.
Well, it is interesting in some sense, as devastating as the lockdowns were, they were straightforward for many people, right? Stay home to the extent you can. And now as some things are starting to reopen, people are starting to struggle with the idea of, if they have the option, of course, many people don't have the option, but if they do have the option of how to return to some sort of economic life. There's a comment in the Q&A or a question that really speaks to the relationship between health insurers, whether they be public or private, and the providers. So this one is, Ohio is cutting capitation payments to Medicaid managed care organizations based on reduced claims utilization. Is that happening in other states? Is the claim experience for Medicaid similar to commercial and Medicare Advantage plans? So I guess here is more on the contracting side between states and managed care plans. Are we seeing these kinds of things happen in the commercial market, Medicare Advantage plans?
Yeah, and if I could just come on the Medicaid piece, and then I would appreciate sort of Larry and Mark's thoughts on commercial and Medicare. On the Medicaid piece, we've been talking to a number of state officials about the Medicaid capitation rates and the slowing down of utilization and what to do about that, and a couple observations just from those conversations. One is some of the plans are saying that the utilization is going to go up, so do not adjust the cap rates now, and there's kind of a conversation going on there on that front. And I think the second piece is some states are also thinking about kind of risk corridor type arrangements so that they can identify, okay, you know, we'll do a reconciliation maybe at the end of the year when we know better in terms of like what your risk actually was over the course of the year. So I think there's different conversations going on to try to address that. But I'm curious about on the commercial and Medicare side. I haven't been tracking that.
Yeah, Mark, I guess your comment earlier had to do with like, you know, the actuaries really are needing to guess these days.
They're in their key. For the commercial side. For Medicare, well, I guess speaking more generally about the fate of hospitals, there's been a couple of articles in the Times about them lately that have kind of irritated me a little bit. One, because they don't seem to have a correct view of hospital financing. So the way this should have worked ideally is, okay, so you've got all these people coming in, at least in New York and Pennsylvania, with coronavirus. Many of them are elderly, so they're on Medicare. Well, Medicare is supposed to pay costs to hospitals, so hospitals shouldn't be losing money on them. Now, Medicaid is supposedly doesn't pay costs, so they may lose money on them, but they should have been okay in terms of covering the resources for the coronavirus patients. Now, of course, because it was such a surge in demand, it's almost certainly true that these patients cost a lot more than their DRG payment rate. And so the Congress has thrown a lot of money at hospitals just for not tied to much in particular to try to patch that up. But and then what of course has been troubling to hospitals is, well, what about the people, the physical therapists, say, who helped out people with knee transplants, knee replacements? We don't need them anymore, but we can't lay them off that fast. There's all these fixed costs, and who's going to help us out with that? So to some extent, the problem, I think, is inherent in the way hospitals are set up, that they have relatively high fixed costs. And so when they experience these unexpected and enormous fluctuations in business, they're in big trouble. And of course, then the other point of the Times article was, of course, not their point, the reporter's point, but my point is that's why the CEOs are paid the big bucks, right? Those $1 million compensation packages, because they're supposed to know what to do in a situation like this rather than complain about how unfair the world is. Well, maybe not, but and as a matter of course, the way it always works, the big salaries are a drop in the bucket in terms of total revenues of these organizations. But the punchline, I think, here is that the hospital system as a whole that operates on a volume-based revenue system is just not set up well to handle dramatic fluctuations in volume, even if total volume stays the same, but it shifts a lot from one kind of patient to another. So when the dust clears, we may want to go back and look at that and see if there's a way to build in more flexibility, either in terms of payment structures by insurers or in terms of hospital structures, organizational structures that would allow them to be a lot more flexible in terms of adjusting to dramatic changes.
I mean, interestingly, you don't hear these kinds of stories from other countries which rely more on global budgeting, for example, for hospitals, which are not sensitive to these changes in volume and might, at least in a pandemic, be a more stable source of financing.
Yeah, you do in some countries like Switzerland, which are more market-based. But yeah, if it's the trade-off. If you make every tub stand on its own bottom and you don't guarantee the hospital revenue with the idea that that'll incentivize it to perform well, The other side of that sword is when, for reasons not the hospital's fault, all the sky falls, so does the hospital.
Yeah, and if I could just chime in, I'm wondering if this is going to propel forward the idea of global budgeting. You know, it's happened in a few places. My understanding is even on the commercial side, there's more of an interest in those models. On the Medicaid side, there's certainly some interest. And, you know, what will this look like? Will there be, at least from a state perspective, enough resources to try to pull something like that off? I think we're certainly getting questions about that. You know, how do we think about moving to more, you know, global budgeting away from fee-for-service in a time when we don't have a lot of internal resources necessarily, but would like to make the leap? So I'll, you know, I'm hopeful that there will be some momentum on that front, kind of across all payers, because I think that's what's needed.
Well, and there is, you know, one of the questions in the Q&A box was how all this will impact CMS bundled payment programs. I think you're all raising the bigger question, which is, like, will this change, maybe even on the provider side, will this change the appetite for more global budgeting or thinking about being paid differently? Because right now, if you're a provider who is in a, you know, capitated environment that was able to maintain some revenues during this disruption, you're probably in a better off spot. Or if you're in a place where there's global budgeting involved. Anyone want to comment on whether or not there seems to be any changing discourse maybe in the provider community about whether or not going through this experience is altering how people are viewing what they're wishing for from the payment system?
Leading up to this crisis, there was growing discussion about the role of prices in driving healthcare spending, and you know, talk of Medicare for all, as Mark mentioned, in the Democratic primary, or a public option that would use government regulation to constrain prices. But both hospitals and physicians, and also drug prices. You know, I think coming out of this crisis, there may be less political appetite to take on hospitals and drug companies around their prices. You know, if hospitals come out of this as saviors, and drug companies also developing a vaccine or antiviral treatments, it may be tough politics to go after those industries. On the other hand, if we see examples of price gouging, I think that could lead to some momentum, political momentum for addressing prices. And I do think providers might have more appetite for a more stable reimbursement or financing system. My suspicion is they won't have much appetite for one that tries to restrain their revenues, though.
Yeah, the interesting thing, I think, is doctors and nurses are going to come out of this as saviors. And David, as a physician, it's time. You guys should strike now while the iron is hot. I'm not sure whether you would go for global budgeting or not at your hospital, but at least in terms of the public opinion about who's done well and who deserves to be admired, it's the frontline providers that really ought to be in a situation to get some reward for their extraordinary service in this period. We'll see if that translates into any financial action, because, you know, gratitude is one thing, but money is something else, especially if you're an insurer, if you're a payer, or even if you're an employer. But even so, it seems like there might be a possibility for some movement there. I do think the problem with global budgeting in the U.S. is you have these multiple payers, and they'd all have to get on board. And then who's going to run the global budgeting? Well, if it's the state, you have the not too glorious history of state rate regulation for hospitals to look back on. At least I remember that. And, you know, in principle, it could work well, but the question is, how well can it work in practice? And whether if you were running a hospital or you're a physician in a hospital, whether you have enough trust of the governmental system, if the government's running it, to think that that's really what you prefer, versus taking your chances with the current rickety system, as many rubber bands and Band-Aids as there are on it to make it run.
So we're getting close to the end of the hour, and so I want to ask all of you a wrap-up question, which is, given what we've learned during the COVID pandemic, what would be your top recommendation to strengthen public and private coverage through this kind of storm that we're anticipating on the horizon? And then even stepping forward, in January, there'll be a new Congress. We'll be post-election, see who's in the White House at the time. What would be your top recommendation for the administration as we go into a new year? So let's start with Larry. You want to go first?
I would come back to some of what Jamila said, and I think what this pandemic and economic crisis have taught us is we need to pay more attention to people who are particularly vulnerable in our healthcare system, in our employment system, and in our healthcare system. And this dual crises of the pandemic and the economic downturn have almost been perfectly designed to spotlight the vulnerabilities. So if you look at who is most vulnerable to severe illness from COVID-19, it's low-income people, it's people of color, it's people with pre-existing conditions. And certainly those are many of the same people who are most vulnerable to losing their health insurance as well. So my recommendation, which is not a policy recommendation, is to focus in on the most vulnerable among us in any policy changes we consider.
Jamila, I know you can give us some recommendations, so let's go to you.
I definitely echo everything Larry said, and I can make a specific recommendation, and to follow up with some of those that I made earlier. I think for me, and I want to preface this by saying I recognize that politically we need to make some shifts in terms of the composition of Congress as well as the White House in order to get this done. But I think universal coverage. And, we all on this call today are fans of the Affordable Care Act and can attest to the major gains that we have made under it. And I think that we can build upon the Affordable Care Act by doing something as simple as adding a public option that could get us closer to universal coverage. I think that is the single most important thing that we can do to ensure health equity in this country.
Mark, do you have a top policy?
I have one serious and one not so serious, but it's so crazy it might work. So the serious one is bring back the individual mandate and bring it back with enough teeth in it or funding behind it that when you require somebody to have insurance, you, from societal perspective, guarantee that the resources are available so that that person can pay whatever you're obliging them to pay. And if they can't afford to pay much, then you have to pay for them to be able to qualify for the individual mandate. So that, I think, could be the tail that wags the dog that makes us have at least the serious conversation we need about what kind of subsidies do various people deserve. I currently get an $8,000 tax break to help me, as a Wharton full professor, afford health insurance. I don't need that $8,000 tax break, although I'm not going to give it back unless everybody else in my income bracket gives it back. But so there is even money there if you actually got into the tax system. But the more fundamental thing is to establish the principle that Americans should be required to have health insurance, and then the political subsidies should be put in place that make it possible for them to do that. That's the serious point. The less serious, but I think still interesting point would be, let's talk about dramatically increasing the wages of people who work in nursing homes, home health care, and other services like that. Those are primarily people of color who are at high risk, about doubling or tripling their wages. And Medicaid could do that, and the government could do it because it pays for many of them, or the bulk of their services. The advantage of that would be not only justice in terms of them having decent wages for the great work that they do. But also I have self-interest that when and if I am going to have to be cared for by somebody, I'd rather they be paid really well so they want to do it rather than doing it out of the goodness of their heart. Although, thank God, in my family, people who've gotten good care have gotten it from people who did it out of the goodness of their heart. But as an economist, I'm reluctant to rely entirely on heartfelt goodness as a motivation, and I wouldn't mind, both from a justice point of view and from an incentive point of view, of seeing those people who provide such an important service appropriately compensated for what they do.
Great, thanks. Emmy, you get the last word.
I think there's an opportunity, don't let any crisis go to waste, right? The famous line of really thinking about how do we want to rethink our healthcare system and the social supports that are related to those systems in areas, like reaching communities of color, readapting to older adults. I mean, we had wanted to do work on that before all of this happened. We have a lot of people aging in this country, and our systems are not designed to address that. So where are we able to transform? And then also rural, the rural hospitals that are out there, some of them in some states are on the brink of not, continuing to operate, really small margins. How are we really thinking systematically and futuristically about those healthcare systems that we have in place that are not right now adapted for the populations that we have appropriately? So in addition to the coverage piece, on the access and service piece, how do we really change those and do more to make them work for our future populations?
Great. Well, I want to thank all four of you. I mean, I think that, what's important to keep in mind in all of these discussions is that there's an extraordinary amount of economic suffering going on in the country right now. And as Jamila mentioned, there are certainly many people who don't have the option of staying at home and are putting themselves at great risk in their occupations in order to maintain wages and hopefully maintain health insurance. And so I think a lot of this conversation has been very helpful to think about what are some responses that would be appropriate to come at the state level and the federal level. And it's certainly evident during these times that the federal government needs to play a very profound role in addressing a lot of these needs and concerns. So again, I want to thank all four of you for spending this hour with us and thank everyone for tuning in. So thank you very much.